871 in medic 6. You're seeing a 74-year-old male, shortness of breath.
As a child grows, they are constantly undergoing physical and developmental changes. Their normal heart and respiratory rate decrease, while their blood pressure increases. Their muscle tone, their coordination, and how they interact socially changes.
The other issues that are different in the pediatric patient, obviously they're smaller, so their airway is smaller, which means it's more difficult to visualize things and often more difficult to manipulate. The tongue is relatively larger in respect to the mouth, also can be difficult for manipulation. And the tongue itself can cause airway obstruction in a patient who is obtunded. When you look down into the larynx, the cords are slanted more anteriorly, which makes them more difficult to visualize in a patient who you're trying to intubate. The larynx is relatively anterior, more forward, and cephalad, closer to the head in the pediatric patient. So it tends to be very similar to intubating that big, obese, older patient where it's very difficult to visualize the airway.
First, let's review some of these anatomical and physiological differences. Children's airways are smaller and narrower than adults. They have larger proportions of soft tissue in the airways. Children have a proportionately larger tongue compared with the size of their mouth than the adult. The trachea is shorter and narrower. There are proportional differences in the epiglottis and larynx. All of these factors make them more susceptible to a variety of obstructions, and each age group presents its own treatment challenges. Other anatomical considerations include softer chest walls that are more flexible than adults. This transfers blunt trauma force to underlying organs and blood vessels within the chest cavity. Also, children tend to breathe more with their abdominal muscles. Any restriction on their diaphragm can interfere with their ability to breathe adequately. These muscles are also weaker, providing less protection to internal organs. Infants are obligate nose breathers until 4 to 6 months of age. Any sort of congestion or obstruction can compromise their respiratory system significantly. Children's heads are proportionately larger than adults. If a child falls, the head typically will lead the body and be the first area to receive the force of impact. Also, the back of the head, or occipital region, is very prominent. When a child is lying supine, it can cause the neck to flex forward and cause the tongue to occlude the airway. It is important to keep the cervical spine in line. Because infants and young children have a higher heart, respiratory, and metabolic rate than older children and adults, they have very good compensatory mechanisms.
Another thing with pediatric patients, which can be very tricky for the pre-hospital provider, is that they compensate very well. They have young, healthy, springy vessels. And what that means is as they lose volume, either from trauma and bleeding or dehydration, those vessels can compensate very well and maintain their blood pressure a lot longer than an adult patient. While that's good for the pediatric patient, I think it can be very confusing for the provider who's used to managing adults. What I always say is you're going to see an adult patient who's getting sicker and sicker do a slow decline and watch their vital signs slowly deteriorate. The problem in the pediatric patient is they may be a little tachycardic but normotensive despite the fact that they have a significant volume loss. And what they'll do is compensate to a certain point and then fall off the cliff. So you need to be able to anticipate that even though a pediatric patient may look relatively good in terms of their vital signs, you're going to need to anticipate and do constant reassessment, because when they do deteriorate, they will do so rapidly, and you need to be prepared.
With this higher metabolic rate, they have greater oxygen needs and greater fluid requirements. Any injury or illness that causes fluid loss, reduction in body heat, or inadequate oxygen will make them susceptible to dehydration, hypothermia, or hypoxia. Illness and stress will further accelerate the metabolic rate, leading to respiratory failure and shock. With infants and younger children, it is important to form a rapid first impression before you approach. The use of the Pediatric Assessment Triangle is unique to young children and is sometimes referred to as the doorway assessment.
The Pediatric Assessment Triangle is a tool to describe your initial impression when you first walk in a room and see the patient. It's something that you can do using just visual and auditory clues, and something that should be completed within about 30 seconds. It's something that the more experienced provider does intuitively, but it provides some measurable things for you to look at.
This quick impression will tell you how quickly you need to continue with your initial assessment.
The first is the appearance. Does the patient have normal tone, normal interaction, normal behavior for a child their age? It's very different when you walk in a room and see a pediatric patient who's running around and playful or fearful and sitting in the parent's arms versus lethargic, listless, and less aware of what their surroundings are. The second thing that we look at is their work of breathing. This doesn't require a full respiratory exam or counting the respiratory rate. It's simply a first impression. Do you see obvious signs of distress? Is the patient flaring or retracting? Is the patient visibly tachypnic? Or do you hear sounds such as stridor or grunting that you recognize as signs of respiratory distress? And finally, you want to look at the patient's color. Do they exhibit signs of pallor? Are they pale? Do they have any mottling, which would suggest some vasoconstriction? Or do they look like a normal, pink, happy, healthy child?
The Pediatric Assessment Triangle is one tool used to help you remember the major assessment points that interact with a child. 3 equal sides remind you that each element is interrelated and equally important. A child's age and the seriousness of their injury or illness will affect how they respond to you. A child that is listless or apathetic during the exam is a cause for concern, but also keep in mind that a child who appears well can deteriorate abruptly at any time. If you identify a significant problem with any of these 3 points, proceed immediately with your treatment and transport decisions.
Okay, how about up there?
Hurts.
That hurts you? Okay. How about I come over to this side? How's that?
Hurts a little.
Little bit? What about up there?
Hurts more.
Hurts more?
In addition to understanding the unique anatomic and physiologic factors in children, it is also necessary to understand the developmental levels. You will be more successful if you tailor your approach according to their age. You will reduce anxiety if you speak calmly, quietly, and use words that are easily understood.
Hi, Olivia. Olivia, I need to look at your arm. Can I look at your right arm first or your left arm first? That one? Okay, we'll look at that one. Lift up your sleeve. Lift it up. Oh, that looks good. Now let's look at the other one. Make sure they're the same.
Children will often regress or revert to a younger developmental level that makes them feel safer when they are under stress. This will also make communication more difficult. Preschoolers, ages 3 to 6 years old, have many different fears and concerns. To gain cooperation, playing games and using distraction techniques can be helpful. Allow the child to handle equipment and assist you. Make sure you include them in the conversation. You can approach older children as you would an adult, but still modify your interactions and your assessment with special technique and care, keeping in mind their unique characteristics and physiology as they grow. Plus, understanding the physical and emotional development of children can help you overcome many of the challenges that you will face treating these patients.